Good afternoon, everyone. We're going to get started with our next climate and health learning series in just a minute here. Before we do get started, I wanted to invite everyone to take a look in your email and see that we are sending post session and a post series for the spring series feedback surveys. And we would love to get your feedback to see how we can improve these sessions to make them the most impactful use of your time possible as we all try to learn about how we can practice more sustainably and figure out what to do about how climate change is impacting the health of those in our communities. I am excited for our lecture today. Dr. Caleb Dresser is a practicing emergency physician who serves as Director of Healthcare Solutions at the Harvard Chan Center for Climate, Health, and Global Environment, and as an Assistant Director of the Physician Fellowship in Climate Change and Human Health, which I would strongly encourage those who are coming out of residency or recently out of residency to consider pursuing if you really want to learn more about how to take a leadership role in this space. Caleb is an assistant professor at Harvard Medical School and the Harvard T.H. Chan School of Public Health. His research and education work focuses on understanding and addressing the health impacts of climate change from the standpoint of healthcare. He currently leads projects developing climate resilience resources for clinics serving patient populations threatened by climate change. And just quickly, before we get to Dr. Dresser, I wanted to tease a little bit for our fall series. We will take a break over the summer and have no lectures in June or July. And then we'll be back in smoke season for Dr. Deborah Hendrickson talking about the impacts of wildfire smoke on pediatric health. We also have lectures coming from Dr. Lisa Patel, a pediatrician, talking about her journey in the climate and health space and how children particularly are impacted by climate change. Drs. Hardeep Singh and Kamal Bajaj will be talking about quality and sustainability and how the intersection of those two things is quite natural. And our closing keynote speaker for the year will be Dr. Don Berwick in December, again, kind of giving a career overview of a career served in many different facets, but ending up focusing on how climate change is impacting our health. So without further ado, I'll turn things over to Dr. Caleb Dresser.
Great. Thank you so much for having me, and great to meet you all. I am going to inflict some slides on you, but I do want to mention before we dive into this that I think we all recognize there are some big issues we are dealing with when it comes to heat and climate change and patient populations that are at risk. And I think we as a community are still learning how to address this, right? There's active research going on. So I'd encourage you, if you have something you want to share on this, to drop that into the either comments or the questions, and we'll try to make sure that we address your point, because I think we have a lot to learn from what's actually getting implemented in practice in a lot of different settings around the country and around the world. Let me confirm these slides are visible. Let me know if they're not. I'm going to be talking today. Looking good? I'm going to be talking today about heat and vulnerable populations. And as Dr. Sims mentioned, I do a lot of my work out of my positions at Harvard. And so this is fundamentally about developing resources and testing them with collaborators in settings in the US and around the world. I do have a couple of disclosures. I have had funding from a couple of private entities for some of this work through Harvard. Nothing that these companies produce is discussed in this talk or is advertised in any way. I've done some consulting work, and we do run a CME course at Harvard Medical School on this topic as well. I want to start with a case, and I think for many of us, this is how we get engaged with this topic, right? We are doing our normal thing, trying to do our best to take care of patients. And something happens where we don't feel like things went right. And that gets our attention, and we say, hey, how do we do better either as a clinician or as an institution or perhaps as a society? And this last case falls into that last category. This was a woman I took care of during my emergency medicine residency in Boston, which is a pretty high-income city with pretty good resources. And nonetheless, this was I think, entirely preventable event. This was a woman in her 80s, so she's a community-dwelling older adult who lives alone. There was a heat wave in Boston. We did not get the kind of temperatures that you see in Phoenix or Houston, but it was pretty hot for Boston. And there's science that we will look at a little bit later showing that it's really comparison to your local baseline that matters for a lot of people. So this woman was experiencing one of the hottest weeks she had ever experienced in her life, and her air conditioning unit broke. She actually had the means to order another one and get it delivered to her apartment, but she didn't have the upper body strength to put it in the window. And so the AC unit sat in a box in her apartment as the temperature went up and up and up. And a few days later, she wasn't answering phone calls from family. They called 911. The EMS team had to force their entry into the apartment, and they found her alive but quite confused with a normal core body temperature and brought her to our emergency department. We wound up hospitalizing her for an acute kidney injury, dehydration, and she wound up having an acceptable outcome. She was discharged from the hospital a couple of days later. But I was really struck by this case because this didn't have to happen, right? If a neighbor or a family member or some other entity had been able to install that air conditioning unit, she probably never would have needed healthcare or certainly emergency healthcare that week. And as we think about the types of things we are seeing, I think heat stroke gets a lot of attention. We're talking about heat-related illness, and I understand you've had some previous talks on, for example, outdoor workers. And heat stroke is a huge issue, and we are definitely going to talk about it today. But I also want to emphasize that when it comes to thinking about special populations, and in particular, older adults or patients with chronic medical conditions, we're going to see a lot of other stuff too, in addition to heat stroke. And so heat exhaustion cases, dehydration and delirium cases, those are also very common and are going to present an increasing burden of disease as we go forward as climate change intensifies. So with that in mind, I want to spend a few minutes talking about heat physiology. The overarching thing we want to get at today is understanding heat, climate change, and then sort of extremes of age and other special populations. And understanding the physiology really helps us understand why certain people and certain populations are at risk. This is my simplified smiley face metric diagram of heat-related illness, which I think provides a reasonable starting point for this conversation. We have all been in this green box. We've walked across a parking lot on a hot day. We've been sitting on a train when the air conditioning goes out. Whatever it is, we've been too hot at some point, and most of the time, we haven't had to move any further down this progression because we go somewhere with air conditioning, or we move into the shade, or we rehydrate and keep sweating and keep cooling our bodies. But in some cases, people don't have the option of doing that. Sometimes that's a physiology problem, right? If you're a water restricted patient with heart failure, this is a really complicated issue. And sometimes that's a social problem, right? If you're a worker who doesn't have access to a bathroom, you may not feel comfortable hydrating aggressively. And so people can develop heat exhaustion. Now, core body temperature may be rising a little bit with heat exhaustion, but it's not dramatically elevated. Proteins are not denaturing yet. This is someone who simply is running out of fluids and electrolytes. And heat exhaustion in most cases is pretty readily correctable if it is identified and intervened on. In a lot of cases, that simply means oral hydration and a meal. For a more medically complex patient, that may mean checking a sodium level and a creatinine and a little bit of IV fluid management. But if this isn't able to happen, whether in the hospital or at home, eventually the body stops being able to cool itself and the mechanisms that maintain homeostasis start to fail. And as that happens, core body temperature starts to rise. In athletes with exertional heat stroke or outdoor workers or members of military or police or EMS who are working hard in the heat, this can happen very rapidly. In older adults who are living alone in a hot apartment where the AC is broken or was never installed, it may take days during a heat wave to get through the first couple of stages here to get to the point where that rapid core body temperature increase starts to happen. And that is what leads to heat stroke, which for all intents and purposes can be thought of as the combination of elevated core body temperature and altered mental status. Really, you're looking at a lot of different types of end organ dysfunction due to hyperthermia. But the one that is going to be most sensitive in most cases is cognition. And so patients will have delirium progressing to seizures, coma, and death if this is not corrected. So we obviously want to break this progression wherever we can. And we're going to talk about some different resources later in this talk for recognizing each of these conditions and intervening on it before it's too late. If we want to think a little bit more about where heat is coming from and how this changes when you are looking at either an older adult or a child, we need to think about the different means through which heat enters or leaves the human body, right? We tend to be, in the climate change space, fairly focused on what's happening as a result of climate change. And so those are changes essentially in ambient temperature, right? Higher outdoor temperatures are happening as a result of climate change. And so people are exposed to that higher ambient temperature. But I think it's worth remembering that there's a lot more to this physiology, right? Whether or not you're in the sun or the shade matters a lot. And so even relatively simple adaptive measures such as shade awnings or trees can be really effective at reducing thermal stress. Endogenous heat production matters a whole lot. If you are a 15-year-old high school football player generating a lot of heat on the field, you're at much higher risk than somebody sitting in the stadium on the same day in the same amount of sunshine. And then if you think about the conductive part here, it's also really important. There have been a number of reports out of parts of the American Southwest, particularly Phoenix, of, in many cases, polysubstance use patients who lose consciousness on pavement that is hot enough to actually cook flesh. And the result is devastating burn injuries from conductive heat exposure. So all of these are potential threats. When it comes to children and older adults, we have to recognize that their ability to deal with these threats is less in terms of the physiologic mechanisms to maintain homeostasis. So what do we need to do as a body to maintain homeostasis? Well, radiant cooling is going to happen from everyone, but it works better if you're able to vasodilate and move hot blood to the periphery to re-radiate heat. Same thing with evaporative cooling, right? You need to be able to maintain hydration, maintain solute intake, and maintain peripheral blood flow. All of that gets harder with cardiovascular disease or certain medications that patients may be on. So this presents a thermal stress challenge for the older adult. What about for children? Well, in essence, while the vascular systems in children are often very healthy and are very effective at moving fluid and heat around, the problem is that children are small. And so the total water reserves in a child are going to be less. And the surface area to volume ratios of a smaller body mean that you are more exposed to your external environment. You have less inertia in terms of your temperature. And so children, especially small children and infants, are at particularly high risk from thermally stressful environments simply because they will absorb heat faster as a proportion of their body. As we think about what we will need to do to counsel patients and to advocate for solutions that reduce risk, we need to keep in mind that this is not just a question of ambient temperature or sunshine. Humidity also matters a lot. And that's because of the evaporative cooling piece of this physiology equation. So the more humid the air is, the harder it is for sweat to evaporate. And as a result, the hotter we feel because it's more difficult to cool down. So keeping humidity in mind matters a lot. For those of you who have been missing medical school and wanted a good physiology diagram, this is what I'm including in this talk. I will share slides at the end, so those will be available. But the basic idea here is that we have a lot of good homeostatic mechanisms, and whether that's vasodilation of the skin or sweating or behavioral changes, right? Delayering, moving into cooler areas. All of these things can fail. And the physiology pieces of this become threatened in older adults who have perhaps comorbid disease or ongoing medication use that might interfere with some of these things. The behavioral pieces are also really important. If we think about why hot cars are really dangerous for children, one of the core reasons that kids can't get out on their own in some cases. If we think about why a unair conditioned apartment is really dangerous for an older adult with dementia, it may be because they won't recognize that they are too hot and are in danger. And so even though they're able to walk and they're able to dress, they may not think to delayer or think to exit that apartment when doing so would be life-saving. And so identifying where these failure points in the system are can help us think about solutions to address them. There is plenty more happening at a cellular level, which I'm going to skip through today since we are really focused on specific populations. But I do want to emphasize, and we'll touch on this again at the end, that there is a lot we can do around prevention as a society and perhaps from a primary care standpoint, but that we also need to make sure that we are prepared to intervene when things go really wrong. And this is where my emergency medicine perspective is really focused on, like, we have to be able to recognize and manage heat stroke. The image here is one of many algorithms that you can find for doing this. This is from a review article that we wrote a couple of years ago. And whichever algorithm you wind up choosing to use, the really key points are that minutes matter. When you reach the point where you have heat stroke in a patient, their proteins are denaturing and tissue damage is occurring in front of your eyes. And so in the same way that we race an ischemic stroke to CT and worry about getting to a really quick thrombolysis if it's indicated, we need to be getting a core body temperature on suspected heat stroke patients, correctly identifying when it is occurring, and getting people cooled down really rapidly. And there are many ways to do that. The gold standard is ice water or cold water immersion, which can be challenging to do from a logistical standpoint. Evaporative cooling can also be pretty effective if you have large fans set up to do it. There's a lot more supportive care that can happen, but the key message here is recognition and rapid cooling. So with all of that in mind, we can see that heat is dangerous. We can see that certain people in society are at particularly high risk, partly for physiologic reasons, partly for behavioral reasons, and partly because of social determinants of health, things like access to safe housing with cool spaces. All of this gets really concerning when we start thinking about what climate change means for heat. So this is climate change summarized in a single slide, simply to point out that we have a lot of steps that have brought us to this point, right? In the background, you can see we've been burning fossil fuels. CO2 is building up in the atmosphere. Greenhouse gases are insulating the planet. The planet is warming and will continue to do so. How much depends on our policy decisions. And the result is a whole lot of different changes in natural hazards and long-term climate. Heat is one of the most well-studied aspects of this change, both in terms of the link between climate change and heat and the link between heat and adverse health outcomes. And so that goes at the top of my list of concerns here, in part because it's so well understood, and in part because the number of people exposed is truly vast. Over the last few years, there have been a series of reports looking at population exposure globally, and it's on the order of a quarter to a third of the global population is exposed to potentially dangerous heat every year. How much has this changed? Well, it's getting worse, and at least in the United States, the number of heat waves in a lot of cities has actually doubled since the 1960s. This is a graph that I like to show, and many of you who are interested in climate change have probably seen this before. This is from the USGCRP's National Climate Assessment. But it's a powerful graph because it doesn't include any modeling. There are no big assumptions built in here. This is simply applying a standardized definition of a heat wave retrospectively to weather station data. And what you see is an increasing number of heat waves over time. The heat wave season is also getting longer. As we look ahead at how much warming we may see, there are a lot of possibilities. And I will stay focused today on the topic of heat and specific populations, but suffice to say that the differences between the colored lines on this graph represent many thousands of deaths from heat stroke, many tens of thousands of hospital admissions from heat-related illness. And so everything we can do to bring down future global temperature change is going to be beneficial at addressing everything else we're talking about in this talk. Why is that? Well, even as we change the temperature of the planet a little bit, we can dramatically increase the number of hot days above a certain threshold. This is one way of visualizing that piece of information. This is from Climate Central. And the idea is that if temperature in a given summer is distributed roughly in a bell curve around some climate norm, if you change that norm by 2 or 3 degrees Fahrenheit, we're going to see, on average, a 2 or 3 degree Fahrenheit change. But if we are interested in how many days above 95 Fahrenheit there are, we may see a far more dramatic change, because when you look at those right tails of the bell curve, you're getting an exponential increase in the extremes. And the extremes are what are really dangerous when it comes to heat. This is also an issue of inequity. This is an inequity issue at both global and local levels and everything in between. From a global standpoint, a lot of the most dangerous heat is going to be happening in the equatorial regions of the planet that are hot, in many cases are humid, and in many cases did not substantially contribute to climate change in terms of greenhouse gas emissions. They will nonetheless be facing some of the most dangerous temperatures in the years to come. And this represents a huge global justice issue and also a huge adaptation challenge from a practical standpoint in a lot of these locations where access to air conditioning is not accessible for most people, and in which the combination of heat and humidity may mean that some interventions may be less effective. Even if we look at a local level, there are a lot of inequities to think about. And these are two maps of Boston. Many cities around the US have similar maps where historical housing practices, redlining, etc., mean that certain populations, in many cases Black and brown populations, are concentrated in parts of cities that were historically not invested in and investors were actually steered away from. And we see that those areas today are very, very hot compared to some of the leafier, greenier suburbs surrounding them. This map also looks fairly similar, if you look at Boston, to a map of where drug overdoses occur and to some of the other maps of social determinants of health. And so when we start thinking about populations at risk from heat, there are a lot of correlations between both the exposure to dangerous heat and some of the patient characteristics or community characteristics that are associated with higher vulnerability. And in thinking about what we can do about that, we have to think about both patient level risk modification and urban or suburban or rural risk modification, depending on which population you're working with. This is one example of what we worry about in cities, which is the urban heat island effect. Many of you have probably heard of this if you're interested in heat. And the basic idea here is that as sunshine hits the landscape, it is absorbed by masonry and concrete and re-radiated at night, and that the lack of shading from trees and the lack of evapotranspiration from trees means that the cooling you get in leafy green areas doesn't happen. And the result is much higher temperatures in urban or industrial settings. So with all of that context in mind, having thought about what climate change means, having thought about some of the physiology, I think we need to talk about more than simply heat stroke. And we will return to heat stroke at the end in some of the algorithms. But if we are trying to look at the whole patient and we are trying to look at the whole population, heat stroke matters, but the aggregate impact of heat on a whole lot of other existing conditions or exacerbations is much larger in terms of the total number of people involved. This slide has just a couple of examples of associations that have been identified in the environmental health literature. If you look at something like kidney stones, it makes a certain amount of sense that you would see a higher rate of kidney stones during prolonged hot weather as people perhaps get dehydrated and solute concentrations in urine increase. There's also a pretty clear stress associated with heat. A lot of that physiology we were looking at the beginning can plausibly be connected with increasing catecholamines and increasing cortisol levels, interference with nighttime sleep. And so it is not hugely surprising that you get an increase in various other disease exacerbations, for example, strokes or other cardiovascular events. And then there are the things that happen when it's hot that don't necessarily kill people, but that do result in discomfort and healthcare utilization and might eventually lead to further problems if they're not corrected. So these are things like dehydration, electrolyte issues, heat cramps, heat syncope. Early summer here in Boston, there is a certain population of people that I will see on Sundays coming from church where they passed out. And, it's presumably because it's warmer in church. People are vasodilating and standing up and losing consciousness. But all of this winds up being quite disruptive for the patients and can lead to increases in emergency department utilization and outpatient clinic utilization. And that shows up in the data when you start looking at health services during hot weather. So what is really going on when it comes to these other events? Well, one way to think about this is a sufficient component cause model. And this was from a paper by Robert Mead, who's a colleague at Harvard, that I would suggest is worth looking up if you're interested in how to think about the physiology underlying heat-related illness exacerbations. And the idea here is that there are several things at play at once, right? Where you have some combination of dehydration, circulating inflammatory markers, etc., and perhaps some underlying medical fragility, and that combines to get a disease exacerbation or a bad health outcome. And so how well we do at managing chronic disease, how well we do at protecting people from heat, both of these are pathways to reduce people's risk. This extends to a wide variety of fields. When I was first engaging with the literature on heat several years ago, one of the things I was most struck by was how basically every body system seemed to have some sort of association with heat exposure. One of the ones that is, I think, most striking and emotional for a lot of people when they discover this is the set of links between either fetal anomalies or early term or preterm labor or adverse birth outcomes and heat, which is not something that, I think had really entered public consciousness, but is something that we certainly need to be aware of, both for advising our patients and also thinking about as members of a community, like how do we make sure that when someone is pregnant, that they're safe and that their baby is safe. So many of us work in systems that are already under strain. And so when it comes to some of the acute disease exacerbations, impacts on EMS and emergency medicine are worth talking about. With what has happened over the last several years in the United States and around the world, any uptick in healthcare utilization presents a real threat to most of the patients in the system because as 911 calls increase, response times will inevitably get longer. And as response times get longer, even if your particular disease exacerbation that day has nothing to do with heat, you might be calling 911 in a system that is increasingly overwhelmed. And what we see in hot weather is more EMS dispatches. The data on the left is from Boston. There have been a number of case studies in the Pacific Northwest in the 2021 heat wave, in Chicago in the 1990s during a heat wave. Data out of the UK has shown this as well, that EMS calls go up in hot weather and can go up quite dramatically to the point where it interferes with response times and the functioning of the EMS system. So this is something that we should be concerned about, even for those of us who aren't exposed to heat or don't work in emergency services. All of this, the heat stroke impacts, the impacts on healthcare systems and EMS systems, and the impacts on chronic disease, all of these things together combine to result in increasing mortality during very hot weather. And when you look at this at the scale of populations, you can use what's called a distributed lag nonlinear model to look at this relationship between temperature, exposure, and mortality, and to look at it over different lags, as in, how is today's mortality related to today's temperature or yesterday's temperature or the temperature 3 or 4 days ago? And when you build these models, you get, in most cases, a U-shaped model where there is a low point that is the minimum mortality temperature. So this is a work that was really sort of pioneered by Antonio Gasparini. This is pulled from one of his 2015 papers, but has now been replicated in a wide variety of settings around the world. And the idea here is that the minimum mortality temperature is actually different in different locations. And so if you compare a very hot location, for example, Thailand, minimum mortality temperature of 30 centigrade, with a relatively cool location such as London, minimum mortality temperature less than 20 centigrade, you're going to see really different things. And this is presumably because of some combination of physical adaptation, cultural adaptation, and also architectural adaptation. And so what we need to do if we're going to understand heat in a given population or community is we need to look at data from that community. If you're in Idaho, looking at my data from Boston may not be that informative. But the methods for building and applying these models are widely available now. A lot of this code is on the internet, and the methods for doing this are achievable by somebody with reasonable statistical skills. And so you can get locally informed models that then start telling you, okay, if you're in Madrid, what is the temperature where heat-related illness is really going to start to increase? When do I need to start being concerned? And that matters a lot if you're in public health or if you're in a hospital trying to plan ahead for this type of event. It also matters if you're thinking about specific populations. This is an image from a paper that came out a couple of years ago looking at the shape of this mortality curve in relation to age. And what you see here is that the purple line, the adults over age 85, have the deepest, steepest U-shaped curve. In other words, they are the most temperature responsive. And so on the right-hand side of that, when mortality goes up during hot weather, a lot of what you're really seeing is mortality among older adults is going up much more dramatically. This should make us really concerned if we care for elders, because it is pretty clear that they're going to be disproportionately impacted during hot weather. For an examination of why, we talked about the physiology earlier. We also need to think about social situations. There are a couple of case studies. One is the heat wave in Chicago in 1995. For anyone who's interested in this topic in depth, I would highly recommend Eric Kleinenberg's book, Heat Wave, for a sociological analysis of what contributed. One of his big conclusions was that social connectivity matters. Another really instructive event was a 2003 heat wave in Western Europe, sort of centered on France, but affecting a number of other countries. And what was seen there was that older adults who lived in the community had a very dramatic increase in mortality. In most cases, they did not have air conditioning. And this heat wave occurred at a time of year when the families, the younger generations, were often on vacation outside the city and weren't checking on grandma. It also lined up with when a lot of civil servants were on vacation. And so the level of public health monitoring and civic monitoring that was going on was less than it might have been. Really tellingly, the oldest adults in France actually had a lower mortality rate than people a few years younger than them, likely because many of them were in institutions with either air conditioning or nursing staff that were checking on them. And so the highest risk was people who had actually maintained their health well enough to still be living in the community. Hugely instructive about the role of social risk in contributing to these events. When we think about where this could go, the numbers get pretty scary. This is a worst case scenario. For those of you who follow climate change modeling, RCP 8.5 is probably a worse future than what is actually going to happen, at least on the foreseeable timescales over the next few decades. So this is an extreme example. But it is instructive as to why we need to think about heat exposure so carefully and address root causes so aggressively. Because once you raise the temperature and the humidity beyond a certain point, you get to a level of heat stress where homeostasis cannot be maintained, even for a healthy adult sitting in the shade. And that is a point at which lethality of heat will become essentially universal. This, in some models, could be expected to start happening by the end of the century. Now, there has been other modeling done since this paper, some of it by colleagues across the river at Harvard, that shows actually we're probably not going to hit this 35 centigrade wet bulb globe temperature within the next 60, 70, 80 years. But when you think about the impacts we're seeing today, it's clear that we're seeing impacts well below these scariest thermal stress levels. And so we do need to keep in mind, like, where are these upper maximums, and how good is the science to understand how likely we are to hit those? And what can we do to avoid a scenario in which millions of people are exposed to lethal heat? So what do? Well, first of all, we need to know who's at risk. As we talked about a little bit earlier, children and older adults are two really high-risk populations, both because of physiology issues and difficulty controlling their environment, right? If an elder is at home alone and not aware that they are getting too hot, they may not seek out a protective space. We also need to pay a lot of attention to people living with disabilities or outdoor workers or others who are active in the heat. I think you spoke about outdoor workers at your last session, so I'm not going to go into detail on that. But I will mention that when you think about the other three populations here, people living with disabilities, older adults, and children, in many cases, there is somebody in the role of caregiver for that person. And so we need to think about not just the individuals who are at risk, but who is taking care of them. What can we do to support those caregivers with knowledge, information, resources to be able to support them in risk reduction so that these people do not have to become patients when it's hot out? Alongside particularly people who are either advanced in age or living with disabilities, there's a lot of medical comorbidities we need to keep in mind. Everything on this slide contributes to risk during heat in different ways. The cardiovascular system is obviously quite sensitive to thermal stress. There's going to be vasodilation as part of our adaptation. We're also going to be losing water volume through sweat. And then you have diseases like MS, where MS flares actually go up in hot weather. And so heat exposure becomes really problematic for people living with what up until a heat wave had been a reasonably well-managed chronic condition. So having a sense of who's at risk can allow us to prioritize them for resources or counseling. Another way to think about this is to also think about how we manage risk in general. For those of you who do disaster medicine or emergency management, you've probably run into this risk equation. And the idea here is that there are many ways to reduce risk. These can range from avoiding the hazard or avoiding exposure to the hazard to relying on people around you to have the capacity to survive the hazard. And so when it comes to heat, this can be anything from addressing the causes of climate change to having a friend who has air conditioning that you can spend time with, and everything in between. The reason I include this is that you can intentionally address specific components of this risk equation through either specific programs or counseling. So for example, if you have a patient in your clinic who lives alone, is an older adult, and you are facing a heat wave at some point in the summer, it might be worth spending a minute with them just planting the seed of, hey, if it gets hot, is there someone with air conditioning who could take you in for a couple of days? And that might be life-saving. So lots of potentially right answers for addressing risk. When it comes to what the specific interventions are, I think, there's a lot of discussion over air conditioning because it increases greenhouse gas emissions. In many cases, we're running air conditioning off of power that was generated from fossil fuels. But it is also life-saving. It reduces admissions for heat stroke, and deaths during heat waves are often among people who do not have access to air conditioning. So I tend to fall into the camp of if people are at risk and we can get them air conditioning, we should do so. How we do that can include in-home air conditioner distribution and installation. It can also mean access to cooling centers, although accessibility and utilization of cooling centers have turned out to be really significant challenges. But there's also more that we can do, right? In some settings, fans may be helpful. It is worth pointing out that once the air temperature gets to about body temperature, fans stop being helpful. Yes, there is a little bit of evaporative cooling if you're like pouring water onto somebody, but in general, fans are unlikely to be protective and may actually be harmful above body temperature. Cooling centers, again, have some ups and some downs. The basic idea here is that you provide a public community space where people can walk into an air-conditioned room and cool off. From a physiology standpoint, this is effective while they are in the room, but doesn't do a whole lot for them once they're out of the room. From a social standpoint, it turns out this is really challenging to implement because the different populations who are at risk may not want to share the same space. An unhoused individual may not feel comfortable going into a shared community space that's being occupied by children. A person who is undocumented may be uncomfortable entering a government building. So this is not a universal solution for everyone, and the utilization of these has been quite variable in different communities to the point where some places have actually stopped opening these because nobody was using them. So this is again something to assess in terms of who the target users would be and perhaps provide engagement, including engagement around transportation so people can actually get to and from the cooling center. Worker practices are also really important. I think you've already covered this in this lecture series. And then social connectivity is really, really important. And when it comes to the populations we're talking about today, caregivers matter a lot, and so do neighbors. And so ensuring that children and older adults have somebody who's paying attention to their thermal comfort and their safety during hot weather is potentially life-saving. New York has implemented a program that actually pairs up young adults with seniors to do a phone call check-in and simply see how they're doing. And if they're not doing well, provides an avenue for connecting people up with resources or calling 911 if that's necessary. This, from what I can understand, seems to have been a pretty significant success in terms of averting heat-related morbidity. So in our last few minutes here, I want to run through a few resources that exist if you are trying to figure out how do I engage with heat in my clinical practice, or what do I point my medical staff at as we are thinking about heat. One of these is our Climate Resilience for Frontline Clinics toolkit. This is something we've been developing over the last 4 years in collaboration with AmeriCares. And the basic idea here is to provide information aimed at free and charitable clinics, FQHCs, other primary care settings, with a big focus on prevention. This includes materials for healthcare administrators, clinicians, and for patients, and in our latest release, also for caregivers. Some examples of what's inside include tip sheets for patients with fill in the blanks so that they can say, put in the address of the cooling center that they're going to use, or identify, which outfit they're going to wear during hot weather. We include information on specific risk factors, notably for some of the populations we're talking about today, dementia, and some guidance for people in the lives of older adults with dementia. Some information for caregivers of babies and small children as well. And so this is intended to be something that's easy to print out with the after visit summary and sort of highlight the pieces that are relevant to your patient. We do have some information for caregivers on thinking about how to deal with environmental hazards, including heat, that are getting worse as a result of climate change if there's somebody in their life that they're trying to keep safe. And alongside our toolkits, we've also been piloting a heat alert system. If you live in a location where your public health department is already paying close attention to heat and sending alerts, you probably don't need this. But a lot of clinics are in settings where that isn't currently happening. And so we've been pulling weather data and heat risk data to be able to send location-specific alerts to clinicians that sign up for this that essentially say, hey, I see your clinic is located in whatever zip code you entered. you're going to be seeing dangerous heat this coming week. Here's how hot it's going to be. Here's who's at risk. And here are links to some of those resources, including the toolkit I just showed you, in case you want to use these with your patients. We've had a couple of hundred people enrolled in that so far and been iteratively improving it over the last couple of years. If you're in more of a management position or perhaps an advocacy position, we did just release some heat health action planning resources, which are available either through a web interface where you sort of select your setting and resource level, or you can just download the whole PDF and get the full list of options. This is essentially a menu of different things you can do to reduce risk from heat for your patients. And these range from conducting telephone-based or in-person wellness checks, to distributing air conditioners or fans or evaporative coolers, to partnering with organizations like Meals on Wheels to do wellness checks when they deliver food. So lots of different examples. Some of these have a really good evidence base. Some of these are more of a description of public health programs that have been implemented and that are believed to be beneficial, but for which research is ongoing. So happy to share links to these afterwards if anyone is interested. For those of you who work with children, colleagues at Boston Children's Hospital have put together some resources specific to children and heat, focused on counseling and prevention. If you Google the Boston Children's Hospital PESU and heat and climate change, you'll be able to find those resources. And then for those of you who work in acute care or EMS or are in a rural family practice where you might be the person who is going to have to manage heat stroke for the first hour of treatment, which is by far the most critical period of this, there are a number of different treatment algorithms out there. All of these boil down to the same thing, which is you need to recognize and diagnose heat-related illness. If they have heat stroke, you need to cool them off. If they have heat exhaustion, you need to get them volume and electrolyte resuscitated. This is from the Wilderness Medical Society. This one is from an article in the New England Journal by Jeremy Hess and Cece Sorensen. This one is from the AFP. This is one from a review article we wrote a couple of years ago. All of these cover similar concepts. And then this is pulled from the training materials for a course that we're running in a couple of weeks, with a focus on sort of what resources do you have where you are in terms of how do you actually rapidly cool somebody down. Again, the preferred approach is cold water immersion. If you don't have the ability to do that logistically, evaporative cooling and ice packs are other options. So as we get to our last couple of minutes, because I want to leave some time for questions, I think it's worth just keeping in mind that we all have roles to play in this. Four of the big buckets where we can do something about this are making sure that we ourselves are educated and that our patients and their caregivers understand risk and understand how to reduce that risk. When possible, we can connect people up with resources, whether that's air conditioner distribution and donation programs, or just giving them the street address or the phone number for a cooling center in your community. And then if we're in an acute care setting, recognizing when we're seeing heat stroke and treating it appropriately. And then finally, making sure when we are sending people home from the clinic or the ER or the hospital, that we have a good plan. I now do this with most of the people I'm discharging during hot weather in the summer in Boston. I'm just like, hey, do you have somewhere to go with air conditioning? What's your plan? And if not, I will sometimes see if I can help them figure something out before they leave. Bigger picture, there's a lot that still needs to happen in terms of studying a lot of these solutions and interventions to validate their effectiveness, understand their cost. And there's a lot we can be doing from an education and advocacy standpoint to make sure people have access to this. It is important that we do this now because we are going to be seeing hotter temperatures in the years to come. This is pulled from a recent IPCC report, the AR6 report, and every possible future here is hotter. Some of them are way hotter, some of them are a bit hotter, but we need to be preparing now because it's going to take time to set up systems to adapt to this and to do the research to understand what will be most effective and most cost effective in terms of keeping people safe. So I will close there, and I'm happy to answer questions by email and answer questions right now for the next few minutes. Thank you for your attention.
Thank you, Caleb. That was a really outstanding presentation. You're quite a fluid speaker. I really appreciate the talk. I have a few questions that I'll just get the ball rolling with. and then we'll switch to some questions from the audience. Um, do you know if there are studies that have shown the financial benefits or payback for these free air conditioner programs? It seems like, 10 air conditioners would probably cover the cost of one hospital admission for a patient coming in with heat stroke.
Yeah, so that is ongoing. There's been some work out of New York starting to quantify that. And there are, I think, 13 state Medicaid programs or Medicare programs that now include air conditioners as medical devices. And so I expect we're going to see increasing amounts of cost effectiveness data from that. I don't have an exact number because it's also going to depend a little bit on how much your AC costs, how much your power costs, and then how much your healthcare costs. The power costs are worth emphasizing. We're actually in the process of running an air conditioner distribution trial in Boston with older adults in Boston to try to get at some of these questions at a granular level. And the cost of electricity is a major barrier to use and is also quite variable within the United States and around the world.
Yeah, I mean, I wonder if it's an opportunity to institute or kind of expand utilization of things like heat pumps, which have a more energy efficient operation as opposed to those window units that you're showing in your thing. Because I know that we could clean the grid, but we could also decrease the burden on the grid by improving our energy efficiency. All these things that I never thought of as being healthcare that really are. Um,
Absolutely.
do you know with the protocols for rapid cooling, how quickly do you cool and to what temperature do you take people out of the immersive baths?
Mhm.
We had Jeff Comp from Arizona talk about their body bag program and, really cool program where they're using hospital resources in the ER. And I know there must be a set percentage decrease or an absolute number you want to get people out of an ice bath.
Yeah, so the simple answer is 102 Fahrenheit is a good time to pull people out. The basic idea is once you're cooling someone, there's actually going to be some momentum in that process, and so you can overshoot. So people should come out around 102 Fahrenheit. Jeff Comp is, they've written a couple of papers on this, and they are one of the people I would point you at for like a group that has some of the most experience in cooling large numbers of heat stroke patients really efficiently at an institutional level. Um, so 102 Fahrenheit, people should come out. Obviously, the logistics of doing this are hard, right? To do actual proper core body temperature measurement requires either a continuous rectal or esophageal thermometer, which may not be accessible if you're in a rural health clinic or an ambulance. And so alternative approaches include, you know, dunk the person in ice water, keeping their head above water and making sure their airway is protected, and aim for about 15 minutes of that and get them out, see how they're doing. There are papers looking at the cooling rate in terms of degrees per minute or degrees per hour, where ice water is going to give you, in most cases, effective cooling within about 10 to 15 minutes.
There's a question in the audience. I want to invite Dr. Wepner to come off mute and ask your question, Bill.
Thanks, Ethan, and thanks for a great talk, Dr. Dresser. My name is Bill Wepner. I'm a primary care provider here in Boise, and one of the things I wrestle with is I give patients medications that help to prolong their life and reduce their symptoms until there's a heat wave, and I'm still wrestling with what to do with diuretics, with vasodilating medications. So can you point us towards resources that might highlight some of the emerging evidence on what to do with these medications?
You have hit one of the research topics I think I am most frustrated by, because your question is one of the key questions. We have pretty good data to show that some of these medications are associated with harm during hot weather. We do not know what the right answer is in terms of medication management. When we were putting together recommendations for our toolkit, we convened expert working groups around this, and we actually pulled in clinical pharmacists and primary care doctors and critical care doctors and on to try and figure out what the answer is here. And for most of the people who are like a heart failure patient on beta blockers and diuretics, and maybe they also have schizophrenia and are on neuroleptics, and all of this increases their risk, we really focused on keeping that patient safe in a cool environment because there isn't data that I am aware of to support making dose adjustments short term in the setting of heat, which obviously adds a lot of complexity. I have had conversations with people about the fact that clinical trial data for a lot of those drugs probably exists archived somewhere, and a suitably motivated and statistically talented group could do a reanalysis looking at where people were and what the temperature was during those trials to try and understand what the dose dependency is. But right now, we do not know the answer. If you land on an answer, we are interested. If anyone wants to read more about the medication implications during heat, we can share a link to a 3-page info sheet on heat and medications that's in our toolkit as well, which provides a pretty good overview of what is known.
Yeah, that would be great, Dr. Dresser, if you could share that with us, and I'll be happy to send that out or post it on our site as well. The Idaho Clinicians for Climate and Health, the co-sponsor of this lecture series with St. Luke's, posts the links to the recordings of these on our website, and we can post information like that there as well, because there's a ton of great information, and I really love that AmeriCares toolkit. A question from the Q&A section about cooling centers. So have movie theaters been explored as an option? And for a librarian in the audience, what would you recommend that libraries stock as first aid kits if they're going to serve as cooling centers, presuming that's going to increase the risk of someone having a medical issue in a library setting?
These are great questions. This is the kind of creative thinking we need. So movie theaters, yes, it has been looked at. In many cases, movie theaters are commercial for-profit entities that are not excited about the people who might be sheltering there for long periods of time being there with their paying customers. And so that can become a complicated conversation, but is one that is probably solvable with the right buy-in from the right parties. Libraries are one of, I think, the most successful implementations of cooling centers because it is a environment that is public, is often cooled, and that many different types of people feel comfortable using. We actually have some resources in the Heat Health Action Planning document on thinking about how clinicians can support that. I do not want to ask librarians to start diagnosing heat stroke in their library. And so I think rather than a first aid kit, I think having a little bit of awareness of what is heat-related illness and when do I need to call a medical professional is probably where I would lean with that. In some settings, in like larger shelter settings, for example, having some sort of medical professional on site is feasible, but in most library settings, it's not going to be. You're on mute.
Has to happen at least once per talk. Question from the crowd, in states like ours that are very conservative and underfund public health, there's probably an opportunity to leverage society institutions like churches, neighborhood associations. Have you seen models that are successful with a take like this?
Absolutely, yes. That is one of the best paths forward. So, a lot of what I was talking about in this talk is the people around the person at risk, right? Who's the family member? Who's the community member? Who's the caregiver? And so some churches, for example, have done a really good job of having youth groups paired up with seniors so that somebody is checking on seniors during hot weather. That's a really good way to leverage an existing community where there's already a lot of trust in order to help put sort of a safety net around people who are going to be at risk. Great idea.
One last comment, and then we'll wrap for today and be respectful of everyone's time, or question, I guess. We just had a symposium on climate and health the first time in the Treasure Valley, and I thought it was very successful. And one of our speakers talked about a way of combating the urban heat island effect of using these cool pavement surfaces to have a higher albedo, to reflect more sun. Have you seen practical real world examples of that? And how much does that mitigate the increase that we're seeing in global temperatures?
Great question. So there have been some trials of this. There was a trial in Burkina Faso of putting reflective high albedo paint on metal rooftops of people who live with no air conditioning in houses with metal roofs. And there was something like a 2.5 centigrade reduction in indoor air temperatures in the houses with the white roofs. So that's pretty cool. That's a passive intervention that can last a long time. In terms of the overall urban environment, you need to coat a large fraction of the urban environment in these highly reflective paints in order to get benefit. And so I think that work is ongoing. Certainly, parts of Boston now have reflective paint on roofs. I tend to think of this as sort of the same way we treat low back pain, where like the ibuprofen won't fully fix it, and the lidocaine patch won't fully fix it, and the Tylenol won't fully fix it. But together, all of these things maybe can get you to some PT in a week. And so I tend to think about high albedo roofs or sidewalks or roads and tree cover and increased shade utilization if you are doing shade canopies as many pieces of the right answer, which is a sort of whole of society approach, like how do we transform to reduce thermal stress? And so I see that as a really good opportunity, but one where figuring out what's going to be most cost effective in a specific community is probably a good idea. If you're in a rural area, painting the road white isn't going to do a whole lot to change risk. If you're in a dense urban area, it might be really, really helpful.
Okay, well, we're at 1 o'clock. I want to be respectful of your time. Thank you so much, Dr. Dresser, for a really outstanding presentation. Again, this will be recorded and posted to our YouTube channel on SAITLIT's YouTube Climate and Health Learning Series, as well as on the Idaho Clinicians for Climate and Health website. And please take a look at your email and fill out those post-session and post-series surveys. We will see you all again in August.
All right. Nice to meet you all. Thanks for your attention.
Thanks, Caleb.